When we reflect on the beginnings of modern aerodynamics, and we're talking Wright brothers here, and we compare that to present day, let's say, subsonic military aviation, there really is no comparison. This is like if I told you that a 1925 Model T Ford is capable of outperforming a 700 horsepower Lamborghini, you'd probably tell me to go get my head examined. Because generally we think in terms of the growth of scientific knowledge as being exponential, over time. It makes sense because we don't have to look far to find scientific breakthroughs that have contributed to the progress of humanity. But I would like to propose that the expansion of at least one domain of knowledge didn't progress, and it may be more accurate to state that it just didn't survive. Because between 1930 and 1950, a handful of scientists were developing a classification for a very elusive bacterial species as the causative agent of malignancy. And after 1950, it kind of faded into oblivion, leaving us to, kind of follow the clues along the trail. So let's take a look. In 1931, Otto Heinrich Warburg won the Nobel Prize for identifying that cancer was caused by impaired oxidation at the cellular level. And as significant as that discovery was, he didn't succeed in identifying the specific mechanism of impairment, what actually caused the cell to employ fermentation as a means of energy production. And I'm going to mention three names here, Now I'm going to mention these three names because not only did they recognize that cancer was a mitochondrial dysfunction, as did Warburg, but they went on to explain in considerable detail the bacterial chemistry relating to causation. And then they went even further and actually developed a course of treatment that resulted in full remedial outcomes with respect to cancerous and tumorous conditions. And here they are: William Frederick Koch, Royal Raymond Rife, and Virginia Livingston Wheeler. This is my mastermind group. These are from these I take my inspiration. An individual breakdown of their specific work is kind of beyond the scope of this discussion, but let me just emphasize what they did have in common. They all postulated that the cause of malignancy or so-called cancer was microbial in nature. They all developed very specific techniques for isolating the organism. They all identified the causative agent as a 40 nanometer cell wall deficient bacterium of a highly pathogenic nature. And the information that they left behind has shaped every aspect of my investigations over the past 18 years. We have succeeded in isolating the pleomorphic organism that Rife referred to as the BX virus because of its size. Wheeler called it progenitor crypticides, which means hidden killer, and Koch just referred to it by its amine group chemistry. We call it the stealth bacterium. Outcomes that are not measured obviously fail to provide potential patients with the confidence that they need to make those critical decisions. The old adage that the proof is in the pudding, it serves our model quite effectively. So let's resume our discussion of the bacterium, and let's discuss briefly the properties of the stealth bacterium. They include activated amine group chemistry, pleomorphic, cell wall deficient, small, very small, 0.05 microns, highly motile, aerobic, highly pathogenic, and has a very low rate of binary fission. Let's talk about the mechanism of impairment, and then I'll tell you how the BX antitoxin actually reverses the pathology. Quite simply, the mechanism of impairment is achieved through the bacteria condensing to form bonds with the little carbonyl group engines, if you will, within the mitochondria of the cell that are responsible for initiating the oxidation of sugars. That's what the bacterium does. It locks up the oxidative mechanism. This brings us to the point in the presentation where we consider the role of the BX antitoxin in the depolymerization of the bacterium's chemistry. The BX antitoxin depolymerizes the stealth bacterium. In other words, we break the thing down to its structural units, piece by piece by piece. So you may be wondering, what is the BX antitoxin? Well, it's a non-toxic biomolecule. It could be defined as a photochemical catalyst designed to modify the toxic secretions of stealth bacterium. It dehydrogenates pathogenic chemistry of the bacterium through oxidative means. It's like pouring hydrogen peroxide onto a sore, but in this case we're actually able to deliver the oxidative effect directly into the mitochondria of the cell by converting the bacterium's chemistry into an antibody that cascades through the bacteria from cell to cell like a forest fire. Okay, we provide the catalytic spark, like a child playing with matches in the forest, and the bacteria provides the fuel, like the trees of the forest, and once the wind takes off, the whole thing burns down. And some people may mistakenly think that this is a homeopathic reaction because the preparation is in fact dilute. They have to understand the catalytic pathways that result in the geometric growth of the molecule, and that explains why some people can do a 1 cc injection and end up with a reaction that grows and continues to grow, in some cases for a couple months. So let's consider some of the clinical aspects of the treatment and touch lightly on the subject of remedial effect. Let's talk briefly about case management. You have two components of what we consider to be a Herxheimer-like reaction. You have the die-off of the bacteria, and then you have the die-off of the cancer cells. Once the bacterium is removed from its vital position in the mitochondria, the cell simply undergoes an accelerated apoptosis and or necrosis. As a result of that, you have all of the cellular products liberated into the bloodstream. Now, mainly we're talking about fats, sugars, proteins, amino acids, but you're also talking about nitrogenous or other cellular waste products, bacterial debris, endotoxins, etc. And this creates a Herxheimer reaction that will produce a response that's similar to a flu, because remember, this is a withdrawal from the bacteria's chemistry. And so some of those reactions that we generally observe are nausea, joint aching, headache, rash, itchiness. Not all of these are going to occur, but many of them will. Blurriness, dizziness, chills, sweating, cramps, mucus secretions, frequent urination, diarrhea, fever, increased ketones in the urine. We'll generally see increased proteins in the urine and the blood, increased white blood cell activity to handle all the cleanup. The body's basically in excretion mode here. You've got vomiting, you've got sweating, etc. And the point I'm trying to make is that there is no shortage of reaction with the BX protocol. I want to discuss with you some of the histological findings or the changes in the malignant tissue that one observes over the course of the treatment. One of the first things that we observe is an increase in pain within the tumor. This is generally described as a burning sensation brought on by the liquefaction of cancer cells in the liberation of their acidic cytoplasm. So you have this lactic, malic acid, alcohol, dumping into the tissue encapsulation and interacting with nerves. So there is a degree of pain associated with that. The nice thing is the pain provides kind of a clinical indicator that helps us confirm the reaction, so it's a good thing. And in many cases, it can be mild to moderate. So let's examine a case. Adenocarcinoma of the breast. She's about 60 days into the treatment. And generally, we're looking at about 90 to 150 days or longer before we see the complete digestion of the tumor. But this makes for an illustrative case in as much as the tumors are externally observed. This is 2 days before the administration of the BX antitoxin. You'll see that the neoplasms are firm, express this indistinct irregular shape, clearly disseminated by metastasis, right? Okay, this is 9 days after the injection. You'll notice that the area containing the newest cells is the first area to be affected. These cells necrose and flake off within a week or so. But I'll draw your attention to both of these tumors. You'll observe that the cancer cells comprising this tissue swell as an effect of accelerated apoptosis. The nipple structure begins to necrose at about 3 weeks, and then you can see that it's fully digested within 75 days. and this is what you see at the end of that stage. Okay? This third malignant structure is likely the most instructive because it demonstrates this change that occurs within the tissue. You can see the swelling, and then by the 39th day, you can see upon histological examination under the microscope that the cancer cells are almost completely dismantled at this point. And what you have is this gelatinous agglomeration rich with embryonic cell types that have formed an abundant supply of small blood vessels that over the next month or so absorb the debris and carry it away with the circulating blood. It's this spongy-like tissue. It's a strange thing to behold because it occurs along physiological lines. This is just what the body does when the bacteria are removed. And of course, this is a couple months into the process, and over the next several months, the area will scar over. And over the course of a year or so, the scar tissue will be displaced and full tissue restoration will result. So in summary, what we generally observe in the malignant tissue is increased tightening in the tumors. Okay, they'll generally go into a state of hyperreflexia. You'll see hypersensitivity or hyperesthesia in the tumor areas. They're going to be very sensitive. And before we see digestion of the mass, we'll always see swelling. Okay, and this is the result of an influx of embryonic cell types that construct this vascular ingrowth for the venous return. You'll see mild bleeding in the tumors, again, from the influx of the reconstructive blood. One event following apoptosis that we readily observe is in the process of converting malignant tissue to its various breakdown products is liquefactive necrosis. And as sure as night follows day, the transformation of the malignant tissue into a liquid viscous mass is going to occur, I guarantee it, regardless of the, if you're dealing with a tumor that's internal versus external, it really doesn't matter. The formation of what appears to be a white-yellow pus at the site of the decaying tumor will cause many a doctor to jump to the conclusion that the condition is somehow being precipitated by a flesh-eating bacteria of some sort, or more fitting still, a tumor-eating bacteria. You can grow protein in this, or grow bacteria in this protein-rich waste product, and it does have to be kept clean if you're dealing with an external tumor, but what we're dealing with is quite different, and it's quite simple. I mean, you have this accelerated cell death, accelerated death of the tumor, and you have the monocytes traveling into the mass to release cytokines, which in turn trigger the white blood cells, specifically the neutrophils, to enter into the waste zone and to begin cleanup. And the neutrophils will then ingest the dead cancer cells, they'll ingest the bacterial debris, they'll ingest endotoxins, and in the process they get big, fat, and ugly, and they die off and they're destroyed by the macrophages. Well, if you think of what is pus, it's dead neutrophils combined with protein, right? So you have to be careful about jumping to any specific conclusions if you have not seen the process of reversal before. Another interesting thing that will most often occur and that we'll observe is the opening and the cavitation of the malignant mass upon absorption of the decomposed cellular material, at least on tumors that are superficial. This is an immune response. These are the things that we will generally observe. The range of effectiveness applies to all types of cancers that we've seen thus far. That would include carcinomas, melanomas, sarcomas, lymphomas, leukemia. I'm not sure if I'm missing any here, but a broad range of effectiveness. It is, very effective with late stage, but the earlier it's addressed, the more manageable the case will be. Stage 1 and stage 2 and even stage 3 is generally a walk in the park. Stage 4 and hospice, there's a greater price to pay for recovery. And I guess this concludes the presentation. Thank you.